So let me start with a very basic and very common question that we encounter almost every day. So my first question is to Professor Bijaya. Patients come and tell us that we have stopped having rice and switched over to roti, which is typically whole wheat, made of whole wheat in the Bengali context. So, I mean, what do you tell, what advice do you have for these patients? Is, I mean, roti or whole wheat a better choice than rice? And what do you tell them?
Well, it's a very nice question and very often encountered question that we come across. I agree that all dietitians are coming across. First of all, the first thing the patients say while visiting our clinic, so I shall be switching off to roti, but I cannot, I don't like roti, what to do? So basically, see, both rice and chapati can be a part of the diet of a diabetic patient. As we all qualified dietitians, we know. Yes, we do agree that rice has got a higher glycemic index as compared to that of the chapati, and also one portion of chapati is going to give us a quick satiety value because of its high fiber content, which rice of the same portion size is not going to give. Because if I am asking one patient to have one chapati, for example, it would be of 30 grams of atta, but 30 grams of rice is going to be so less that it is not going to fill their appetite. So in that case, filling the appetite is also very important. So there are a few tricks that if we can do, if we can conduct, probably can lower the GI of the rice, and can the patient can enjoy the rice as well. Firstly, several of the researchers has been showing that uh, the rice, if can be combined with oil and protein and fiber, basically the glycemic index goes down. So technically speaking, the Chinese fried rice with the veg fried rice, or maybe the mixed fried rice, if not adding the ajinomoto, has got a lower GI than the plain white rice because of the fat which is coating the starch and thus letting a very slow release of the glucose in the bloodstream. Number one. Second thing is proteins are very important. So when, at what time I'm having the rice and how I'm having the rice is also very important. So probably, as we have been hearing in all the conferences, and even we have been practically implementing it as well, like probably if we can jacket it with the fiber and the protein, like if I'm having the rice, but if I'm having it with lot of, or maybe starting the meal with the fiber, then rice, having it with the protein, then again some fiber, so that way even the person is eating very little rice, the person is already feeling full after having a lot of salad, maybe before they're starting off the meal, or maybe the sprout salad if they're having. So that way they would be getting the protein, they would be getting the fiber. Then if I'm asking them to have small amount of rice with a katori of fish, and for the non-vegetarian, of course, the fish. For the vegetarian, of course, they can go for the paneer and all. So that way they would not be feeling hungry. So we need to see that what can be given. So talking about the whole wheat and the white rice, yes, whole wheat has got low GI, but talking about the white rice, as I've said, the various things can be adopted to bring down the glycemic index. So some smart tweaking is applicable. Apart from that, also if the patient is so eager to have rice, we can also shift to the different forms like brown rice, red rice, black rice, although not everybody can afford it. So probably for them, even the mota chawal that we use, if they can use that, so even with a small quantity of it, they feel full because the rice, it swells up more. But yes, it
Yeah,
has to be
so
taken with a
essentially,
pinch.
and parboiled rice, thank you so much for your
Yeah.
inputs. I think parboiled rice is also a very good option. And here in
Yes.
Bengal, that is more, I mean, we mostly eat sheddho chal, that is parboiled rice. That is,
Correct.
I mean, has a better glycemic response when compared even to brown rice. And
True.
so essentially what you're trying to emphasize is, of course, portion control is very, very important for
Yes.
both rice and roti because they have the similar carbohydrate and calorie content. But yes, roti has a higher I mean, whole wheat has a higher fiber content, even higher than brown rice. And so essentially, nutrients, you've talked about nutrient sequencing and combining it with the, I mean, when rice is taken as a part of a mixed meal, which is very, I mean, we Bengalis, we generally do have a
Yes.
very good mixed meal. So that is essentially what you have talked about. And I think it's better to avoid all the processed rice products like, you know, too
True.
much of muri, the more of the puffed
Mm.
rice, and the diet chira and these forms. should be avoided. Otherwise, as long as it is taken as a part of a mixed meal and the strategies that you have explained very well. So thank you so much for your valuable inputs. So can we?
So, coming to the next question
Yeah.
here. Now, what in our part of in the Delhi, now wheat and rice are the poor man's food. Millets have
Mhm.
taken over,
Yeah.
right, Shimanti? So
Yes.
millets are the fashion food. People are going gluten free, and especially for diabetes, millets are now being considered as the holy grail. So, what is it?
Yes.
Is it a myth? Is it a truth that everybody who has diabetes should just give up wheat and rice and just take over on millets? What is your take?
Yes, ma'am. Thank you for the question. So I would like to highlight on the goodness of the millets first, because as you rightly said, that northern India is totally dominated with millets because it's the area where millets are really cultivated so well. We belong from that part of India, that is eastern part of India, or if I talk about the southern part of India, they are using both millets and rice, but we are a rice dominant region. So if I point out the goodness of the millets at first, I would like to mention about the dietary fiber rich quality of the millet first, and definitely naturally being gluten free, and definitely they have almost 7 to 12% of protein, 2 to 5% of fat, and 65 to 75% of carbohydrate, which is not less than that of rice and wheat. But if I consider the main points, that is the micronutrient quality of the millet, so in that case, we find that the major millets as well as the minor millets. The major millets like the jawar, bajra, ragi, and the minor millets like the foxtail, kodo, proso, or the barnyard millets, they are a powerhouse of B vitamins as well as niacin, phosphorus, potassium, antioxidants, which act as phytonutrients as well as magnesium. And the data shows that bajra and barnyard millet are rich sources of iron. Barnyard millet gives around 18 milligrams of iron per 100 gram, as well as bajra gives 11 milligram of iron. And how can we forget about ragi, which gives an essential amount of calcium, which can be a great substitute to even a weaning diet, as well as in a diet where people want to go lactose free, as well as need substitutions to get their calcium in the diet. So ragi gives us around 350 milligram of calcium per 100 gram. And if I talk about other protein content of the millets, that jawar bajra will give us around 10 to 11 gram of protein per 100 grams, and even ragi, foxtail, and proso are giving us good amount of protein. So if I compare coming to rice and roti, definitely rice has a higher glycemic index, but as Vijayadi and Priyangidi really nicely pointed out, that the way that we are consuming rice matters. Similarly, the way we are consuming millet would matter. There are many meta-analyses, there are many studies which have showed that millets are a great source of cereals when we incorporate in a diabetic diet. They have shown good results in maintaining the postprandial blood glucose response as well as bringing down the HbA1c levels. But as we can see that if we are having millets, those which are polished, that is available in the market in the form of millet flours or ready to eat cereals, that would not be effective because that would be of a higher glycemic index compared to the unpolished millets. So the type of millets that we choose in our diet is important. So completely giving up on roti and rice is not a solution because it's a continuous dispute that millets versus rice, millets versus roti. But I think having a different nutritional composition, having a different cooking potential, having its own culinary variety, as well as the environmental implication, millets have gained a lot of importance. But definitely I would not suggest giving away of roti and rice. And also I would like to mention another point, that is what ICMR NIN data suggests, that 33% of our daily cereal can come from millets. So I would say that introducing millets in one of our meals, when if I'm introducing first, like I'm a first eater of millets, introducing the lighter millets first and then moving on to the heavier ones would be of a good solution. And so we can substitute our breakfast or lunch or dinner and check our blood glucose response at how it is helping us. And the way we are eating millets is also important. That is, if I am comparing that with rice also, so adding some acidic medium or an oil content to rice reduces the glycemic index, or incorporating that with the proteins as well as the fiber. But if we are having millets also, if I'm having it in a huge portion, considering the goodness of the millets would not be really helpful. The portion size, the choice of the
Right.
millet is important. So
Absolutely, Shimanti. So, if I have to summarize, you're saying that millets definitely are a power source of nutrients. They have fiber. but
Yes.
only if the bran is there, not
Yes.
if they are refined. Thirdly,
Absolutely.
we don't need to give up wheat and rice. We
Yes.
can have millets in 1 or 2 meals in the day, but we
Yes.
totally do not need to remove rice and wheat. The other
Yes.
thing is the minor millets like foxtail millets and porso are one of the richest protein millets that we have. And then also in millets, also we have to be very careful of what we eat the millets with. So we still have to add more protein and fiber in the millets and include healthy fats along with millets to make a complete meal, right?
Yes. And
And we have
also,
to keep cycling the millets. It's
yes,
not that
yes,
we just stick to one millet, right? That's
absolutely.
that's
That's what I want to
entire.
point. Yeah, ma'am. That's what
Correct,
I want to
correct.
point out. Rotation of millets would be really helpful, and totally giving away is not never a solution because the glycemic index is absolutely not much
Yeah,
less. It's a moderate to high glycemic index that
yeah.
the
See,
millet.
actually, the carb content of wheat and
Ab-
the different millets are nearly the same. The
Yeah,
glycemic
yeah, yeah.
index of rice is higher, but the wheat and the
Exactly.
different millets are nearly the same, right?
Nearly the same.
Yeah.
Exactly.
So, can we have the next question, Priyangi? Thank you, Shimanti, for the answer.
Yes. Now, my next question would be to Mr. Aritro Khan. Now, we had been having a very interesting conversation on the carbohydrate sources. Now, another very important area is, and recently there is a lot of confusion regarding the use of, the alternative, the sugar substitutes, especially the non-nutritive sugar substitutes. So, I mean, we all know it has been linked with, they have been linked with a lot of health concerns from cancer to, gut dysbiosis and, there's increased chance of CV risk and all of that. So, and most importantly, the very recent WHO guideline advising against its use for weight reduction. So, of course, patients are concerned and they come and ask us whether to use or not to use. So, could you please tell us, like, where do we stand currently in terms of the use of non-nutritive sweeteners?
Thank you, Priyanki, for this very relevant question. And in the lieu of this very empirical discussion,
Aritra,
so
yeah,
basically, what has happened, Priyanki, what you have asked regarding the artificial sweetener, previously the artificial sweetener were thought to be effective in the treating the obesity and diabetes because artificial sweetener is something artificial, and there are a lot of meta-analysis, there are a lot of studies, and there are a lot of published in this journal. They have said that artificial sweeteners have no effect on the body weight or the glycemic control. But however, there are some recent studies, what you have rightly mentioned about the WHO and the other meta-analysis studies. They have said that the artificial sweeteners affect the glucose absorption as well as this is the intestinal tract and the insulin and the incretin secretion in the humans and animals, because a lot of studies done with the animals, not directly in the humans. But moreover, the artificial sweeteners, after there are a lot of composition of the microbiota, what you have mentioned about the gut microbiota, they have worsened in the glycemic control and the weighing to the changes in the gut microbiota. So basically, the artificial sweetener have the very debatorial subject in different ways, because sometimes they have said it's a no role of the obesity and the diabetes or the glucose management, but the other studies they have said that they're actually controlling the glucose absorptions in the intestinal tract as well as they are controlling the worsen of the glycemic control in the gut microbiota. So their early intake of the basically the acetylsulfame K was also been shown to the suppress to the taste to response to the sugar, because any kind of the artificial sweetener that we have see that they are much more sweeter than in taste, like maybe 150 times much more sweeter or 300 times much more sweeter than the normal table sugar. So in that cases, and there are a lot of cohort studies, they have suggested that the high artificial sweetener intakes were associated with lot of comorbidities like cardiovascular risk, like coronary artery disease, like coronary heart failure, cerebrovascular risk, as well as you have rightly mentioned about the cancer risk or any other palliative care. So treatment of the diabetes and the obesity should be reconsidered, and the replacement of this artificial sweetener in patients and requiring a long-term observational therapy. Maybe you can prescribe to a patient a certain amount of the dosage according to ICMR or NIN and WHO, maybe GRAS, generalized recognized as safe, 30 grams per day, not more than that. different on different classes of the artificial sweetener, but the long-term observation, long-term association should be very important. Not only the intake, but also the change in their blood, their body weight, their glycemic control, as well as the gut microbiota segmented. So there are different artificial sweeteners
So
that they are
talking about,
basically.
yes.
Basically, we are talking about is if you talk about like stevia. So stevia side is there. So there are very little amount of the stevia that you can take. And if you talk about the aspartame, the basically a dipeptide methyl ester, which is FDA recommended in 1981. So these contain the phenylalanine, and which is again a detrimental for the patient suffering from the phenylketonuria. So heating temperature,
And
adding the aspartame.
Auditro, just
Yes.
tell me, I mean, you are talking about the interaction with the gut microflora. I mean, do all the non-nutritive sweeteners, do they have the same effect, or there are certain sweeteners which particularly
Yes.
are
Yes.
related, and there are others which don't have an effect? So,
Yes.
I mean,
Yes. In that case, what I've mentioned that there are a lot of studies with the acesulfame K and the aspartame that has been mentioned. But if you talk about the sucralose, they basically come from the sucrose. So these are artificial sweeteners you can take, but moderately. But if you talk about the stevia, that you can take moderately. But there is a big no-no about the aspartame, a big no-no about the acesulfame K and the other artificial sweetener. Again, artificial sweetener, I have told you, is a deleterious effect because there are a lot of studies, meta-analysis says that it is no effect to our health, but there are a lot of meta-analysis state that they are the different of the non-communicable diseases and the syndrome X. So moderation is the key. If we say to our patient,
absolutely. I mean, that is, I think that is the foremost thing that we must remember, that moderation is very important, and different sweeteners have different, I mean, they have different chemical compositions.
And
so their
Priyangi,
effects
I would like to say one thing, that from your post, you have some post a few days ago in the social media that there are different companies that using the artificial sweetener, but they have contained the sucrose and they are trying to giving the marketing gimmick in front of the patients, but that is not done.
That is a different topic or a different discussion altogether. If we have time in future, we can carry on the discussion. But essentially, when it comes to non-nutritive sweeteners, the basic points that we can, if we have to summarize, or what I understand from you is, there are different types of sweeteners and each have a different chemical composition. So their effects are different. So of course, sucralose is safe in pregnancy. It's the FDA approved sweetener in pregnancy, but sucralose, saccharin, and stevia, they do interact with the gut microflora. And there are others like aspartame and acesulfame K, which relatively do not have not been found to interact. So I'm not going into the details. So, and we are very clear that the ADA, the latest standard of care, it has mentioned that of course moderation, as long as they are taken within the acceptable the ADI daily intakes, I mean, that is fine. So basically the diet foods or the diet colas or the diabetic products which can contain the tons of these products, it's better to avoid these. But if you like, it's very important to assess the amount of sugar a patient is taking in the first place. So it is just, if it's just 1 or 2 cup of coffee or tea in a day, so like little bit 1 or 2 tablets per day, or in their daily cup of coffee or tea is perhaps okay, because we need to the long term implementability of the diet is more important rather than restrictions. So can we move on to the next?
Thank you, Priyangi. We'll go to the next question and we'll go away from the little controversial sweetness to the non-controversial intermittent fasting, which has now proven beneficial for most of the people for weight loss. But for people for diabetes, Dr. Arna, the question is for you. For people for diabetes, does intermittent fasting has any more benefits than just weight loss? Is it really beneficial for people with diabetes? Can it just cause weight loss, or it has more benefits beyond weight loss?
Thank you, ma'am, and thank you, Dee, for giving me this opportunity. to discuss about such a relevant topic and diabetes and intermittent fasting. Specifically, we have to understand that fasting and calorie restriction, these are two different perspectives. Fasting means somewhere deprivation of nutrient, and when we are restricting calories, that means we are restricting the, we are substantiating our diet in such a manner that will provide us the nutrient, but the calorie will be curtailed down. So the question is whether the fasting, intermittent fasting, is truly helpful for the metabolic syndrome in diabetes or hypertension or any other form of metabolic syndrome. See, initially, if you see for the rodent analysis, we have to understand that human are completely different compared to the rest of the eukaryotes. Most of the eukaryotic models which have been, exposed to this intermittent fasting, prolonged fasting, and different forms of fasting, there are a lot of IGF-1 and insulin like growth factor 1 binding protein. So these are the substance, even some pro-inflammatory cytokines like TNF alpha and all that, their expression level will goes down whenever you started following some intermittent fasting. There initially you will find a remarkable result. Initially you will definitely find a remarkable result. There will be, ketogenesis and the lipid, that lipolysis and all that, the way body wanted to accommodate the nutrients and all that, that will be initially, it will give a very good result. But slowly the studies, they says that, even it has published in Nature also, even a lot of opioid also come out, that whether the intermittent fasting or the calorie restrictions are beneficial for, particularly for the diabetic people for metabolic syndrome. Means intermittent fasting initially will prove a better result, but slowly body has a great adaptive mechanism. That is the issue. Like, whenever you will started curtail down some of the nutrient by using, because you are restricting food, means 16 hours of gap and then 8 hours of window will be available for the food, like, or some, in like 1 or 2 days of fasting, like this way also people are moving forward. So initially body will adapt to this and will show some good result, but slowly body has a tendency to make an homeostatic regulation. And with that homeostatic regulation, whenever that window will open up, the body will shoot up the glucose and all that other macronutrients whichever available. And that is not an initial, that is not an ideal for any metabolic syndrome patient, even for the obese also. That is, means in a long term manner, initially body, body water content may come down, and may people may feel that no, we are getting a good result because visible differences are coming out. But slowly body will adapt, because rodent, they don't have any other work and except that experimental work. But the human has to go to the office and they have to do the job, because brain will, they will start the way brain functions, and lot of our hypothalamus and pituitary axis that associated with all the metabolic pathways, even the gut microbiota. So far the what we have been discussing, like, if you just restrict the food for a certain window, what would be the consequences about our large intestine? Because large intestine will exposed for a very short period of window. So in that part, whether the micronutrient, the microbiota, whatever available there, they could be available to utilize it and produces the heat shock protein or G protein coupled receptors and all others which are associated with our your short chain fatty acid productions, and the way they regulate our macrophages and monocytes. So if you are, means, moving towards this chronic continuous intermittent fasting, I feel that, means, that is my personal observation, or like way I have understood this particular scenario. This is not the ideal way to move forward. That is always better to go for the calorie restriction rather intermittent fasting, this procedure. Because the more, the way, or the once the body will adapt this situation, again the metabolic syndromes and all other consequences will come forward. And this is not the ideal way to treat your body, like, microbiota and all other entire system which is associated with this. So the better way to calorie restriction rather than intermittent fasting. That is my personal opinion about this take. Thank you.
So, Dr. Arnab, what you're trying to tell us here is that initially the intermittent fasting may benefit the person with diabetes beyond weight loss. Also, it may decrease inflammation, it may improve the overall health, it may decrease the cholesterol, but long term, it may not
Yes,
have the same effect.
you're
And
right.
patient might even
Yes.
feel more hungry, more tired, more fatigued, right?
Yes.
Is that's
Yes.
what the
Because a lot of
and the regular calorie,
neurodegeneratives.
yeah. So the
Right,
regular
right.
calorie restricted diets that we follow are okay. So is
Best.
not intermittent fasting the same calorie restricted diet?
See, intermittent fasting and the calorie restriction, when you are providing for a metabolic, particularly for the diabetic person, like, they have a small portion of meal is much better, I feel, in when you are regulating and when you are playing with the insulin. Means because the regulator of our energy expenditure is insulin. So we have to be very, very cautious about how it is working, because even the micronutrient also, because the absorptive sites are mostly that jejunum and duodenum, and once you are restricting the food for a certain window, you are actually making your this intestine to means remain empty. So the prokinetic work of the intestine, that also may get altered for a prolonged period of time. Like, you are restricting them to work for 16 hours and you are allowing them to work for the 8 hours. And so the way intestine used to work, so that is also getting somewhere hampered. So initially when you
Right.
are restricting that, you will find a remarkable result. But the long term,
Correct.
because the only the longitudinal studies are available for the rodent model, because rodents, see, they don't have to do any other work
Yeah,
except
that's
the
what you mentioned. They
experiment.
don't have to work like us. The other
Yes.
thing, certain people with diabetes who are on insulin, who are
Hmm,
on sulfonylureas, should
hmm,
not do intermittent fasting, is my message. And the other
hmm,
people who should not restrict the carbohydrate content in their diet or follow any kind of fat diets are the people on SGLT2 inhibitors. So
true.
I think we have had a very, very wonderful discussion on myths of diabetes. And I would really like to thank our wonderful panelists who have given their inputs on these questions and taken the time out today for us. Thank you, Priyangi. Thank you, all the panelists.
Thank you so
And
much.
thanks to all the audience who has been with us through this panel. Thank you.